you all are here to join us. Hey, Mimi. I'm thrilled that we also have Kathi Miracle. Yes, that is her last name. She's here to talk to us about a very I don't want to say popular, but it seems like it's an important conversation for all of us this morning based on the number of folks that are here. So without further ado, I would like to let Kathi Miracle take over, and she is our executive director for one of our memory care communities here in Louisville. So Kathi Miracle, take it away.
Well, thank you all very much for getting up on a Saturday morning. I'd like to welcome everybody. We have people as far as Ann Arbor, Michigan. Thank you so much for coming and joining us today, and all over throughout the Denver metro area from a lot of our different Balfour communities, and then also from our own Louisville campus. So the audience is growing bigger and bigger for our dementia webinars, and so thank you all for being here. Welcome. I have worked in senior living since I was 22 years old, and I'm 52 now. So I have done this for about 30 years. Dementia is my passion. I have a master's degree in gerontology with an emphasis in dementia and elder abuse. And so I love, this is one of the things I truly love to do, is educating different individuals, whether it's families, whether it's professionals, as part of the dementia journey and what they can expect as part of that journey. And this is actually, Louise and I were talking a little bit this morning, this is the topic I actually get asked to speak on the most, is physical aggression, sundowning behaviors, and why we term it a little bit differently actually when I work with individuals in my own building. So we're going to go ahead and get started because this is a lot of information to cover.
Hang on one second.
Okay.
Let me make sure I can forward your screen. There you go.
Okay, there we go. Okay, so we're going to talk, what we're going to cover today in this presentation is the importance of the discussion. We actually, I like to not call it behaviors, but emotional expressions, and why. What defines an emotional expression, what are emotional expressions, why do they happen, the common challenges, and how to possibly manage emotional expressions. And then we'll cover questions. And actually, let me just stop right there. If you have a question, ask it, go ahead and ask it, because a lot of times it pertains to that information we're talking about. You do not have to save your questions to the end. It's fine. Let's ask those questions as we're talking about the information. And Louise can help field those questions, whether they're in the chat or if you want to raise your hand. Louise is going to help me field those questions as we go along.
Yeah, and to that end, just because we have quite a crowd this morning, I have everybody on mute. So if you do want to ask a question, please unmute yourself or raise your hand if you know how to use that feature, or just start, if you have your camera on, just start waving at me. Kathi?
Yep.
Oh, go ahead.
Go ahead. Next slide.
Oh, sorry. You're waiting for me. All righty, here I have to go here. There we go.
Okay, so the reason why I always believe the discussion is important is because anybody with a cognitive challenge who ends up with a diagnosis of one form of dementia, or even professionals who work in this field, you're not going to go through the dementia journey without seeing some type of behavior. You're just not. When we do this training in the professional world, I usually ask my staff, how many shifts do you think you're going to work before you actually see a behavior? And the answer is one. You're going to see it usually on your very first shift. As families, if you're caring for somebody with dementia, as they progress through their dementia journey, you're going to see them. It's inevitable. And so the discussion is important, because what I tell my staff is the goal here is to be proactive, not reactive. If we can be proactive in their care, we can minimize what we have to work with. Huge. It's absolutely huge. And we can reduce people's anxiety, the caregiver and the person living with dementia, a great deal, so that the transition, or so that the journey becomes a lot easier for everybody involved. Next. So here's kind of early on, I want to kind of make sure we get something very clear, is that somehow the word behavior has been negatively linked to people living with dementia. So if you look at the list on the left, emotional expressions, this is what people express when they're living with dementia. These are actually the things that happen. And for those of you who are caring for someone with dementia, whether you're a professional caregiver or you're a family member, you can probably identify with some of these things. And I'm actually going to go through these things. And if you look at the list on the right, behaviors, these are things that we all do every day. We walk across a room, we pick up a glass and we drink from it. Some of you smoke a cigarette. We take showers, we wash dishes, we drive a car. So we all do behaviors every single day, but not all of us have a diagnosis of dementia. And so that's why I say it drives me a little crazy when working in this field, is just because that word has just somehow been linked negatively to a person with dementia. So I really prefer the term emotional expressions, although getting an entire industry to change that mind shift is really difficult, because it's not going to happen. But really what the person is having is an emotional expression. Next. Okay, so I'm going to just dig into this a little bit deeper. So when someone with dementia is having an emotional expression, these are the things that we will typically see. We see hitting and screaming and yelling. We see a lot of combativeness, crying and biting, throwing things, pulling hair, pinching and spitting, isolation, rocking, pacing. Now, this is the one that I hear a lot, is I hear people say, well, they're not wandering, or they're, exit seeking. So what I want people to understand, I want to cover this just a little bit here, is that there's actually a difference between purposeful wandering, non-purposeful wandering, and exit seeking. And that's the thing that people get confused all the time. And it's also when I know that someone either does understand dementia or someone does not understand dementia. So exit seeking is pretty clear cut. That is someone who's actually banging on windows, banging on doors, is, jiggling doors, trying to get out of a building, trying to get out of a house. And that is, I want out of here. And there's a reason they want out of here. Either something is agitating them inside of that room, or they don't want to be there, or they're looking to get out the door somehow. And sometimes it's like, why do you want to get out? They're looking for their car. They're wanting to go home. There's some reason behind the message that they're trying to say. What I find more often why the agitation goes up, 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 up is because somebody is telling them no, 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 no. And it's much like if you tell a teenager no, or a small child no, they want to do it that much more. And so what you'll learn is that individuals who are caring for the person with dementia tend to make the situation worse, not the situation better. And we're going to talk about that a little bit more. But oftentimes, when I hear somebody, they're exit seeking, or they're pounding on the door, or they're wanting to get out, usually if you just kind of say, like, people will say, well, I'm trying to find my car, and they're trying to get the exit door. I see staff getting so nervous, like they can't let the person out the door. And I'm like, why can't you let them out the door? I can assure you, some of these young girls who are 22, 23 years old, I'll bet you can run faster than the 80-year-old woman on the walker. I'm pretty sure you could. And so I got to go, well, let's go look for your car. And I find staff, they get almost this look of horror on their face because I'm letting the 80-year-old lady with the walker out the door. And I'm like, well, let's go look. And we walk outside and they look around. I'm like, do you see your car? Nope. Okay. Well, how about we go back in here? And you can almost get them out the door, walk them back in less time than you can while they're still banging, 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 banging on a door. And then they're not anxious, and then they're not agitated. I find that food works really, really well too, if you can say, if you talk to them a little bit while they're outside, and then you can also, say, I know it's about snack time, or I'm getting kind of hungry. And there's a trick trick to it too as you're doing it. Or if you take cookies with you, and I don't see anywhere to sit down out here, and make sure there's nowhere to sit down outside too, because we have benches right outside our doors. Let's go back inside and let's share a cookie. Okay, that sounds good, because they're going to get tired of standing there, and you can get them right back in. So exit seeking is really the pounding on the doors, pounding on the windows, and getting out. Okay. Now the wandering, and most times when I do this training, people have never heard of purposeful wandering versus non-purposeful wandering. The purposeful wandering, a lot of times it happens more at home than it does really in a community. It can happen in a community if it's in their own room. So really what that is that they're doing it in a pattern. Okay, they're like it's a circular pattern usually. What they're doing is they'll go to a picture. Maybe it's a picture when they were on vacation and they actually touch it. Maybe then the next thing they go to is a vase, and the vase is something, maybe it was an anniversary gift from somebody. The next thing they go to is maybe it's a little thing they bought on vacation. Maybe it's a little trinket or something. But what the person is doing is they're going to things that they can still identify with, and it means something, and they're connecting with it. And actually what they're doing is they're self-soothing. And if you watch them, it's a pattern. All right. For the caregiver, I've listened to caregivers go, oh, they're driving me crazy. They're walking around all the time in the house and they're just driving me crazy. And caregivers actually stop it, because they'll say, come and sit down and eat something, or come and sit down and watch TV. Because it's driving the caregiver nuts that the person is wandering. Or I had one caregiver say, they're putting a pattern in the carpet. And I'm like, so, and it was driving the caregiver more nuts, and the caregiver kept stopping the wandering, this purposeful wandering. Please understand that when someone is doing that, the person with dementia is self-soothing themselves. They're bringing their own anxiety down, because that individual a lot of times knows they're forgetting. Like, they're in this certain stage, they know that they're forgetting. They're frustrated, they're overwhelmed, they're anxious. And by being able to purposefully wander in an environment that they can go to things they still connect with or they still remember, they are bringing their own anxiety down. You don't want to interrupt purposeful wandering. That is something that just let them do it. As much as it may be hard on you as a caregiver or drives you nuts, you don't want to interrupt purposeful wandering. And it'll be a pattern. You'll know, because their breathing stays even. They have a peaceful look on their face, and it's okay. Now, non-purposeful wandering, that's a different story. That is more very jagged. It's like they're creating a star. They're going from point A clear across the room to point B, then back across the room to point C, then back across the room to point D. They look troubled. They're frowning. Their breathing is different. We see that more in communities because it's a new place or it's strange. They might be wringing their hands. Their anxiety is actually going up. That is absolutely something we want to jump in on, because that's going to escalate. And then all of a sudden it's going to come to a breaking point. And then that's when we start seeing the crying or the screaming or the combativeness or the spitting. That's when we start seeing that. And we don't want them to get to that point. So the non-purposeful wandering, we want to jump in on after the first couple of jagged moves, and we want to redirect the person, or we want to de-escalate the situation. Purposeful wandering, leave it alone. Non-purposeful wandering, jump in. Exit seeking, jump in. Those are the things we have to be able to identify with those individuals, and then be able to say, okay, how can we redirect? And I'll explain how you can redirect and how you can be proactive here in just another few minutes. Next. Okay, so stages of emotional expression. So this is also kind of the stages of dementia. So there are actually 7 stages of dementia. In the last month when we talked about it, there's actually 5 domains that get affected and 8 cognitive losses. So this is your stages of dementia. I didn't make the stages of dementia, someone else did, but actually stage 1 is no cognitive impairment. So everybody here today is in stage 1 of dementia. Yeah, that should make everybody happy, right? But stage 1, Stage 2, you don't really see emotional expressions. That's just people being human. Stage 3 is when you really, I call it the smoke and mirror stage, because that's where you start seeing people in mild cognitive impairment. That is someone is kind of saying, look over here while I band-aid my world over here. You see people having maybe a lot of sticky notes. You see people having a lot of notes in a calendar. They're trying to connect their world like Band-Aid approach, really. And this is also where, as spouses, as children, as support services in their world, we help excuse it away. Because mom or dad or spouse, they get frustrated, or we start seeing them repeat themselves, or we start seeing funny things happen. And we are all busy in our own worlds, right? We're raising children, or we have busy jobs. And if we start to see something, we might go, is everything okay? Are you all right? And they just go, I'm just so tired. It's just been a busy day. And we kind of go, yeah, I have busy days too. I understand why that happens. It's okay. And we don't really question it, because how many times have we ourselves opened the refrigerator and go, was I taking something out or was I sticking something in? Right? Or we walk into a room and we go, what was I walking in here for? I don't know. And we walk back out. So we don't want to think at our age, we're getting dementia, right? And dementia is actually the second most feared diagnosis in the United States. The cancer of any kind is the most feared diagnosis. So certainly, because Dateline, 2020, 60 Minutes, nobody paints this diagnosis to be a pretty picture. And so when we start seeing those signs in other people, we kind of get nervous ourselves about the journey we may be on, because nobody plans for this. Nobody wants it. Nobody wants to be on that journey. So at stage kind of 3, when we start seeing that, we help people excuse it away. Really, we do. When we get into stages 4 and 5, that's when we start seeing these emotional expressions. I talk to people about, if you know who Kubler-Ross is, that was a psychologist who wrote the 5 stages of grieving. It's denial, bargaining, anger, depression, and acceptance. And it was really built around when someone passed away. But I apply those 5 stages of grieving wholeheartedly to when someone has a diagnosis of dementia as well. And you go in and out of those stages so frequently, and nobody in a family is ever in the same stage at the same time. And so we see a lot of that with, this couldn't be happening. Oh my gosh, God, if you could not have my mom have Alzheimer's, please. And then there's the frustration and the anger that goes with this. And I used to tell people all the time that this is the most mentally, physically, emotionally draining roller coaster you will ever find yourself on. And I had a daughter tell me one time, Kathi, you're wrong. This is not just a roller coaster. It's an entire amusement park, because sometimes the ride is fun. Sometimes you walk in and you don't want to get on the ride at all. Sometimes you get off the ride and you're just sick and you want to get sick. Sometimes it makes you so dizzy, you don't want to get back on the ride at all. So this isn't an easy journey. And when you start getting involved with the emotional expressions, it makes it a lot harder. So you start seeing these emotional expressions around stage 4. It gets really hard in end of stage 4 into stage 5. They start start going away around stage 6, and into stage 7, it just gets kind of a lot easier, because the person is mostly on hospice and they're a lot calmer. Not that it doesn't happen, they're just easier because the person is weaker and they're at the end of their journey. So that's kind of, you kind of go up this hill and then you kind of come back down it. But it's, and that's why I say it's kind of like a roller coaster. So this is not an easy journey to be on. Next. Okay. So why do emotional expressions happen? So if you look at this, as long as I've done this in my career and I've watched what I've watched and also been a part of it, like I said, I started my career as a CNA in a nursing home on an Alzheimer's unit when I was 22 years old. And back then, back in 1992, 1992. They taught me how to bathe, dress, feed, shower, transfer, evacuate a building, but I never got taught how to redirect, de-escalate, approach. I never got taught any of that. So I was hit and kicked and punched and scratched and thrown in a wall, and my ribs were broken because I never got taught how to work with people with dementia. I had to learn it on my own, and it's why I've created the trainings I have, because I don't want my staff to get hurt. And what I've learned over the years is about 80% of the emotional expressions we see, we trigger as individuals. Only about 20% of the emotional expressions we see is actually due to the dementia. So what happens is we as individuals who are caring for those with dementia, we communicate too fast or we communicate too much. And the person with dementia can't keep up. What I've learned over time is I learned what the brain does when it's normal, and then I learned what happened to the brain as it got damaged. There are 128 different types of dementia. 7 of those are actually pediatric. The youngest person in the world to have been diagnosed with a form of dementia was 4 years old in the UK. So when you work with different types of dementia, you have to understand, okay, how does that type of dementia affect this person? And a lot of times as professionals, we use this blanket approach with people with dementia, and that's what triggers a lot of the behaviors, because we're using a blanket approach. And you can't approach Alzheimer's the same way you do Lewy bodies. You can't de-escalate vascular the same way you do frontal temporal. Now, we don't work with 121 types of geriatric dementia in our communities, nor do you work with 121 types of dementia in your personal lives. So knowing the type of dementia we're working with absolutely is important, although a lot of times what we hear from doctors is, you know, you have a type of dementia with or without behavioral disturbances. Okay, thank you. That would be like telling somebody, you've got cancer, we're going to treat it. Well, do I have breast cancer? Do I have bone cancer? Do I have liver cancer? Do I have lung cancer? What kind of cancer do I have? And doctors are going to approach bone cancer differently than they approach breast cancer. And so it makes it challenging when we don't know. But somebody, like, if we know the temporal lobe is damaged from a communication standpoint, that's a lot different. And how we process language that we hear is in a different part of the brain than how we process language that we speak. The processed language that we hear is in your temporal part of your brain. The parietal part of your brain, in fact, the left parietal part of your brain is how we speak. And then what we read language is in a different part of the brain. And we just, I just here in my own community had a lady come into the building, and as we go through the dementia journey, as they speak language, we call it word salad, but they're trying to speak something, but they're not getting it out. They know what they want to say, and they get very frustrated because it sounds like a bunch of gibberish to the person hearing it. And as I was working with her, I went to the hospital to talk to her and assess her. I wrote different words down, and she could read them, no problem. And she understood what they meant, and we could communicate if I wrote them. But if she tried to talk, I couldn't understand what she was saying. So learning to use a communication board with her was a great way for us to be able to communicate with her, but her trying to talk was not going to work. So understanding that those are 3 different parts of the brain is going to help decrease that and be able to decrease her frustration and decrease my staff's frustration. So we're not going to trigger behaviors, but understanding and knowing that that's 3 different parts of the brain is very, very important in us to be able to communicate with her and take care of her. And so that's why I said that has nothing to do, her frustration isn't her dementia as far as us triggering the behaviors. It's just understanding how to communicate with her. And that's why I said we can't just talk to her. We have to use a different form of communication. Approach, very, very, very important. So we don't ever want to approach somebody from behind. You will scare them so badly. So the person with dementia, if you can take your hands and just go out 45-degree angle, that's their world. Anything behind that, that is no longer their world. it's kind of like when I do trainings with staff or at conferences, my kids now are I have two 17-year-olds, and when they were 10, roughly about 10 years old, they could hear me coming home and from the garage, and they loved to jump out and scare me. They loved it. And so when you're startled, what is the first thing you do? Well, first of all, you jump, you scream. And the second thing is you want to whack the person who just startled you, right? And that's what happens in the person with dementia's world. If somebody comes up from behind them and they startle them, their world is no longer what's behind them. They don't hear it, they don't process it. So if somebody's approaching them from behind and touches their arm and says, "Hi, Jim," they're going to get startled. And the next thing they're going to do is reach out and smack whoever startled them, right? And so then all of a sudden they get labeled and says, "Well, Jim's having behaviors." Jim's having behaviors, what happened? And then Jim's medication gets changed. Well, Jim wasn't the problem. It was the person who approached Jim the wrong way who startled Jim. That's what happened. So don't ever approach somebody from behind. You want to, if you're coming from behind, walk up until you're in front of them at a 45-degree angle and then say hello to them. The other thing I see is if you approach somebody from straight on, people as they age sometimes will obtain cataracts, glaucoma, macular degeneration. And when we do this in training, I actually have people take their fists and put it right in front of them. So they're like this, about maybe 2 to 3 inches in front of their eyes. And I'll actually approach them dead on, dead straight on. Sometimes I approach them pretty fast because in our communities, my staff is always walking like fairly fast because they have 10,000 things to do. And I'm like, you have to be person-centered. You cannot be task-oriented. And when they get into these trainings and I'm small, people who, I always say people look taller on computers, but I'm 5'3". And so I'm not that tall of a person. And so when I'm approaching them straight on, I say, "Tell me when you can see me." And I can get usually within about less than a foot of them before they know I'm on top of them, and it startles the staff person. And they know I'm coming because we're in training. And I say, "Okay, now we'll do the exercise again." And I'm coming at them from a 45-degree angle, and I'm easily 3, 4, 5 feet from them when they can see me. And I said, "Do you understand the difference then when you're approaching an older individual with dementia, and you're doing it at a slower pace? Do you understand the difference and the importance of approaching somebody first slowly, secondly at a 45-degree angle instead of straight on and at a fast pace?" And they get it. They understand why this startles somebody and why the other one is much more important. Because one, you're going to trigger an emotional expression and you're going to startle someone. And the second thing is that we don't want to be triggering those emotional expressions. So approach is very, very, very important. The other one is medical need. So when we're looking at a medical need, it's not that we're not being attentive to somebody's medical need. However, sometimes somebody with dementia, maybe they're taking pain medication as needed, and what they really need is a pain medication scheduled. Or they're taking 200 milligrams of a pain medication, and what they really need is something like 400 milligrams. I worked with a daughter at one point, and she said, like, I watched her mom get up and walk across a room, and the further her mother walked, the more grimace her mom got on her face, and the more harder it was for her mom to walk, and her mom started stooping, and then her mom started swatting at me. And as I sat her down, I said, I really think that a good part of the challenge is your mom's in pain. And she said, "Oh no, she's not." And I go, "Oh yeah, I think she is." And she said, "Well, I asked my mom if she's in pain, and she says no." And I said, "Okay." So from the time we're little kids, little toddlers, until the time we pass away, I think the most common word we hear in the English language is no. And so we are conditioned in our lifetime to say no. Because if you think about those of you who have little kids, those of you who've raised kids, as soon as your toddler starts crawling and starts walking, what do they hear a lot? They hear, no, get away from that. No, don't touch that. No, don't do that. No, no. And as they grow up, what do the kids hear a lot too? Mom, can I have this for Christmas? Mom, can I have this? Mom, can I do this? Can I do that? No, 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 right? As we get into the teenagers, and like I said, I have 2 teenagers. Mom, can I have 20 bucks? Mom, can I have this? Mom, can I? No, I'm not an ATM. No, you can't do stay out till midnight. No, we hear a lot of no's, and then as we get into adults, we have to learn to live within a budget. No, we can't afford that more expensive house. No, we can't afford the Tesla. No, we can't do this. No, we can't go on vacation. We hear no a lot. And I always tell my staff, if you were out on a car lot looking for a car and I walked up to you to my bat with my little shiny name tag, right? Or you're in a retail store and I'm walking towards you with my little shiny name tag. And all I said was, hi, how are you doing today? The first words out of your mouth, I didn't even say, the first words out of your mouth is, no, I'm just looking. No, I don't need any help. No, we're conditioned to say no. We just are. I used to in college have the highest retail sales when I worked in college, because when I walked up to people, I would say, hi, how are you doing? And that's what people would say. Oh, I'm just looking. I say, oh, I'm not here to help you. You're in here all the time. I just wanted to tell you, that blouse makes your cheeks look really rosy. And they go, oh, well, thank you. I'm like, I would start off with a compliment. Always started off with a compliment. And then they go, well, while you're here, can I ask you a question? Sure. And by the way, this is on sale up front. I didn't know if you knew that. And so I always started with a compliment, and then I'd end up with sales every single time. So what I'm telling you this is, as we get into our dementia world, usually any question we ask a dementia person, are you hungry? No. Are you thirsty? No. Do you want to go to the bathroom? No. They are just usually the first words out of their mouth is no. So it's why we don't ask yes or no questions in dementia world. What we say is, do you want to wear the blue shirt or the red shirt? Do you want the chicken or the pork? So if we say, are you in pain? They're going to say no. So usually you want to say, where does it hurt? Does it hurt in your knees or in your back? Does it hurt in your ankles or your hips? If you ask a yes or no question, more than likely, you're going to get a no answer. So when it comes to, are they hurting somewhere, what you want to watch for, are they grimacing when they get up or when they get down? Are they walking slower? Are they just, what is their body language and what are their facial expressions? Sometimes they'll actually grunt. They kind of go, when they're getting up. Nobody makes that sound usually unless they're a little bit in pain. So sometimes emotional expressions happen because they just don't feel good or they're in pain somewhere. So asking a yes or no question, are you in pain? That's probably not going to give you the answer you want. Probably, where does it hurt? That might be a better question to ask. Environment. An overstimulated environment or even an understimulated environment can be problematic. People think, those of us who have environments going all the time, it's busy, 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 busy. When I say that, I always get a chuckle like, oh my gosh, I'd give anything for me to just be in a peaceful environment all day long. Okay. And sometimes I go, oh, if I could just have no phones ringing, no questions, anything like that. That lasts for about an hour. Me and 2 colleagues actually did this, where our families got up and left for the day. I got up, I sat, no TV, no phones, no anything. And for 8 hours, I ate when I was supposed to, I went to the bathroom when I was supposed to, and nothing, no stimulation for 8 hours. And when our spouses came home, what they were supposed to do is like, how pleasant were we or were we not by the end of that 8 hours? Every spouse reported we were a little edgy and a little grumpy at the end of that 8 hours. So no stimulation at all. It actually can also trigger an emotional expression. So you have to have some stimulation. Even Maslow, hierarchy of needs, okay? If you look at his hierarchy of needs, the very bottom says food, shelter, water, and human touch. If you don't have human touch even, you can become very cranky, So if you don't think you can, go 48 to 72 hours without human touch. And if you're going to do this, please tell the people around you that this is a test. Don't not tell them that this is, let them know. But an understimulated environment can lead to emotional expressions. overstimulating environment can also lead to emotional expressions. If you have somebody with dementia, I've been called out of my office in different various communities I've been in because, you know, our staff is saying, you know, Kathi, Joe is out of control. I need you to come help. Or, you know, we can't calm Susan down. And I'll go to wherever they are, and where the environment is, we've got a TV going, we've got a radio going, we have family members talking, the staff's doing something, and I walk into the scene and I close my eyes and I think, how many noises is this person's brain trying to process? And it's a lot. So if anyone has ever experienced a migraine headache, do you want to be in a car with a bunch of kids with the radio blasting in rush hour traffic? No. You would rather have your head in a pillow in a quiet room, maybe dark, because you can't handle all the noise. And that's kind of what it's like for somebody with dementia. Their brain no longer has the ability to filter. So for you or I who are cognitively unimpaired, if we're sitting in an office, we can filter out what's going on outside of our office. Like there might be noises or discussion. We can filter out all of that noise. However, the person with dementia no longer has the ability to filter. Its brain is going to try to process everything it hears. And at some point, that is so overwhelming for those individuals, they cannot process it anymore. And so it's just too much, and they become very overwhelmed very quickly, and then they just start shutting down. And that's, again, when they've escalated to the point to here, they've gone up this escalation pattern, and now they're here, and now they're doing the screaming, the yelling, the crying, the pacing, and we're now being reactive, we're not being proactive. So the environment can trigger it too. Next. Okay, so when emotional expressions are happening, it's usually because there's an unmet need. They are thirsty, they are hungry, they are tired. You know, when I was pregnant with my daughter and I was going through classes, you know, they were saying, you know, your baby's going to have 6 different cries. I thought, oh my goodness, 6 different cries, because they have a cry when they're hungry, they have a cry when they're tired, they have a cry when they're hurt. And so as a new mom, you have to learn which cry goes to what. This is kind of no different. You know, a person with dementia is trying to communicate something's going on. They need to go to the bathroom. They're tired. Something's happening. And so they need to understand, you need to understand what they're trying to communicate. So like I said, about 80% of the time, we're triggering the behaviors because we're doing the things I just told you about. Only about 20% of the time are those emotional expressions actually due to an unmet need. And so if we're paying attention, then we can anticipate the need too. So if we know it's been a couple hours since they've eaten, and we have them on a good schedule, like, okay, a lot of times with dementia, the 3 meals a day may not work anymore. If they're grazing throughout the day and having like 6 little meals a day, we can be proactive and they shouldn't be getting hungry. If we're watching and at the same time they're having those meals, we're having a little bit to drink, they shouldn't be thirsty. If we have them on a bathroom schedule and we're reminding them to go to the bathroom every couple of hours, and then they shouldn't have to go to the bathroom. Doesn't mean they won't. It just, we can be proactive when we have them on a good, solid schedule. You know, but we still have to be paying attention and watching, because there still could be an unmet need. They might be too hot, they might be too cold. So we just have to pay attention and try not to ask yes or no questions. We talk about understimulating and overstimulating environment. We talk about the physical environment, you know, how many people are in it. We talk about, you know, maybe there's somebody in the environment that somebody long ago reminds them of. I've had that happen where people who come into their environment, we had a gentleman who another resident reminded him of somebody who stole money from him in his past. So we had to do some quick rearranging of people in his environment. I've had a gentleman, we had a care staff person who, while not Japanese descent, reminded the gentleman, and he actually served in the Navy and was stationed in Pearl Harbor when it was bombed. So those are the types of things we just have to be mindful of, because that was actually going to trigger things for him. So we had to take that person and the employee and just move them to a different part of the building. So those are the types of things when families move residents into our building, it's really important for us to know the social background so that we can stay away from certain topics, so we can avoid certain things that might trigger emotional expressions. We talked about approach. We talked about medical need. How is the person being treated? It's really important, and I talk to my staff about this all the time. We want to call them by their proper name. We want to make sure, I've been given permission in the past to, like, one gentleman, he was never called grandpa, he was called Pops. So the family gave us permission to call him Pops. I had one lady, she was very proud to have been married to a doctor. So we always had to call her Mrs. Dr. Smith, I think, something like that. So because she loved being called that. I really try very hard from a professional standpoint to make sure my staff is not doing the honey, the sweetie type of things. It's like that when I'm training, I tell them, when you go to a restaurant or you're checking out at Walmart and your person, your waitress or your checkout person is saying, "Hey, honey, did you find everything you need?" I said, "How does that make you feel?" Because they don't know you. And staff will kind of cringe a little bit. And I'm like, "Oh, yeah, I don't like it." I go, "Okay." So for the person with dementia, maybe we've lived here 6 months, you're still somewhat new to them and their world. You don't have a relationship with them. This is a professional environment. Let's not be doing that to them, because it actually can trigger an emotional expression if they're not used to you in their world, because you're still new to them. And so we try to be supportive, and if the family says it's okay, that's one thing, but if not, let's make sure we're calling them a proper name. For family members, sometimes it can be challenging because your loved one may not see you as their daughter anymore or as your spouse anymore. And so it can become very difficult and challenging. And I know it can be emotional for you as well. So I would caution you on how they're being treated, only because it can actually trigger an emotional expression for you at home as well. If they were in the military, sometimes their rank, they might be more agreeable if they were a colonel or if they were a sergeant, because they will align themselves to how they were in the military. That was their regiment there too. And so you have to play with it just a little bit, only because if they feel like they're being treated disrespectfully or they feel like they're being treated condescendingly, especially men who held high-ranking positions in the military or in a company, like they were a CEO or they supervised a lot of people, it can actually trigger emotional expressions, and it can be problematic, and it can become very quickly a challenge for you. So I've had staff who actually had a staff person we had to educate quite a bit, because I had a lady who had a lot of stomach challenges, and she would say, "Does your tum-tum hurt?" I'm like, no, do not talk to her that way. She's not a child. And so let's be respectful of how we are treating our residents. So we got to be very careful that we're not treating them in a disrespectful way, because it can become very challenging. The domino effect, this happens in senior living communities. It does not happen taking care of somebody at home. But what this is when you've seen people who've already escalated. You get one person who's escalated and who's gotten to their tipping point, and they have what we call burst. It's as soon as that person has burst, it can actually cause 2, 3, 4, 5 other people to burst, and it's like watching fireworks go off. And you just see this domino effect where one person goes, 2 people go, 3 people go, 4 people go, and it happens so fast that instead of now working with one person who is having an emotional expression, you now have several people who are having an emotional expression, and it all at once. and staff don't know where to start, and they don't know how to redirect because it's all happening so quickly, so fast. It doesn't happen often in senior communities, because usually you can take the one person or two people and be able to redirect and separate them quickly. But it does happen, and when it happens, it's very challenging very quickly. It's all hands on deck with very many staff people to separate people very quickly. So it's not fun. And that's why I tell my staff, when you start seeing one person start to pace or starting to get agitated, it's why you also want to be proactive and not reactive, because as soon as you've experienced the domino effect, you don't ever want to experience it again. Next.
Kathi, is how does sundowning, what is sundowning and how does it fit into these emotional expressions?
Okay, so sundowning, that's a really good question. Thank you for asking. So sundowning can actually start as early as noon or 1 o'clock in the afternoon, and it actually can go as late as 10, 11, midnight. So it actually is a large span. There's kind of this myth out there that it only happens between 3 and 5 or 6 p.m. That's the peak of when it can happen. So the reason how it got its name is that if you look at how the outdoor lighting happens in the morning sunlight is very consistent and it's very steady. So if you look at your lighting in your house, the lighting outdoors, the sun creates a light that's very steady and consistent. In the afternoon, the sun outside and even the lighting in your homes or communities, all of a sudden you start to see more shadows. The sun creates inconsistent lighting in the afternoon. So people with dementia start seeing more shadows. That creates more delusions, it creates more hallucinations. And so as the sun starts to go down in the afternoon, that's how it got its name, sundowning. And then for individuals, they just start having more emotional expressions. They get more anxious, they get more challenging. That's when there's more activity happening. Kids come home from school, people come home from work. There are more shift changes in hospitals, rehab, skilled nursing, assisted living, because your shifts are usually 6 to 2. So the shift happens at 2 p.m. or 7 to 3. Shift change happens at 3 p.m. Sometimes it's 7 to 7, 6 to 6 in hospitals and rehabs. So there's just more things that happen in the afternoon in people's lives. And so there's more changes in their lives in the afternoon. So sundowning can happen, and people look for kids to come home from school. People look for their spouses to come home from work. I have to start making dinner. The shadows are happening, so I hear more things, I see more things, there's somebody coming after me. So that's why you see that those emotional expressions happening more during those times of day. So what we try to do is we look for the comforting things. So when if we can go to the next slide, and I'll show you, because the next slide I think shows all of the emotional expressions. Oh no, it says common challenges. Okay, so here, let me talk to this. So when you have, anytime people get overwhelmed, if you are, and this is any human being, from the time you're born to the time you pass away, dementia, no dementia, any one of us, when you are scared, overwhelmed, angry, frustrated, upset, any of those emotions that we feel, your brain actually releases a chemical. The chemical that, what happens is it craves something sweet, fatty, or salty. So when you think about your own life experiences, you know, the boyfriend that broke up with you in high school, or you got fired from a job, or you're stressed out because you have this project, whatever it is, if you think about how your coping mechanisms kind of are, you think about what you go to, usually people are going for pizza, chips, fries, ice cream, chocolate, beer, wine. Any of those comfort foods will land in one of those three categories: something sweet, something salty, something fatty. And so what we try to do, let's just say when the sundowning is happening, and I know that Betty, right around 3 o'clock every day, she's going to start pacing because she's going to start looking for her kids to come home from school. Then roughly about 2:30 or 2:45, I know Betty loves 2 scoops of vanilla ice cream and chocolate syrup. Hey, Betty, how are you doing today? You know what? Come here. I have a wonderful snack for you. And you do? Mm-hmm. Oh my gosh, vanilla ice cream. I love vanilla ice cream. Okay, why don't we go sit over here and let's talk, let's have a chat, okay? You know, I think you had 3 kids when you were growing up. You know, you raised 3 kids, didn't you? Yeah, tell me about your children as she's eating the ice cream. Okay, so we can do a reminiscence conversation, and maybe we have pictures of our kids, and we can already, as that chemical is going to start releasing around her sundowning time, I'm already satisfying it with something sugary for her, and we're reminiscing about her kids. And so as she's starting to already climb this little thing, we're already de-escalating it before she ever gets to here with something sugary to satisfy that chemical, and she never gets to that point. And that's, again, being proactive, not reactive. Does that answer that question? Okay, great. So some of the common challenges that we see, bathing's the big one. That is the big one, I know, for people. And so the Alzheimer's Association actually has a video called Bathing Without a Challenge. And so some of the things that I can tell you that's in that video is they will do the same thing. They will serve ice cream. They will serve cookies. They will serve chips. I can't tell you how many times I've done that while somebody's bathing. Because again, as people are getting anxious about having the bathing process, that chemical will get released in their brain. So I know if I'm going to have a challenge with bathing, how about we have some ice cream or chips or cookies or something as we're going to the shower room or the bathroom, and we already start satisfying that chemical before, again, we're doing this as they're climbing this anxious ladder. They never get to here because we're already satisfying the chemical in the brain. The other thing with bathing is, you know, as people age, their skin gets a lot thinner. So when you're having a shower up here, hit skin, very thin skin, it feels like needles. You don't want needles hitting skin, that hurts. Also, people's skin is a lot thinner. It's cold. They don't want to be cold. So one of my creative things that I've done is those big beach towels you can get, if you lay it out on the floor and just pick it up in the middle and just cut a hole in the middle, put it over somebody like a tent, it creates an insulator between the water and the skin, and then it doesn't hurt as bad. The other thing, this generation, the only time they were undressed was in front of their doctor or in front of their spouse. So they don't want to be undressed in front of you. It's a dignity thing. By using this towel as a tent, they're still covered. They're insulated. It's warm because it creates some heat in there. If you pre-suds it before, you know, and then let it dry, then when you go to give a shower, it's already sudsed up. You can bathe them really quickly and then, you know, take it off real quick, rinse them off and put them in a robe. You can get somebody bathed in less than 5 minutes, and it makes it less challenging to get them bathed. Dressing and undressing is always a challenge. Sometimes they want to have their very favorite jogging suit on. I had a son one time go out and buy 12 the exact same jogging suits for his mom. She wore the same outfit. It was just she had 12 of them. And so we would say, it's time to get, she'd go, oh, I don't need to get dressed. I have this on. And we'd show her, hey, here's your favorite jogging suit. She wouldn't look at what she already had on. She'd go, that is my favorite jogging suit. And she'd start undressing herself. And so we would put the same outfit on her. It was just a clean outfit, and take the other one to go wash it. So it, you know, you have to get creative sometimes when you're working with people with dementia. The bathroom challenges, I usually don't tell someone, hey, it's time to go to the bathroom. Somehow they will suction themselves to the seat they're in. I usually will just say, hey, do you want to go for a walk with me? And people love going for walks. We just happen to end up in the bathroom. Eating can be a challenge. We want to keep people independent as long as possible. And so we will use the utensils with the big handles or scoop plates, even letting them eat finger foods as long as they're continuing to eat on their own. We talked about wandering and exit seeking. We've talked about communication, sleeping. As people progress through their dementia journey, you know, if you think about their brain really is damaged. So what it takes for you or I, like if I'm going to pick up a cup and drink from it, it takes my brain that fast to get the message to it. For somebody whose brain is damaged, it's going to take the brain longer to get the message from point A to point B. So it would be like if you were trying to travel and you hit construction or you hit an accident or something, and you're trying to get from point A to point B would normally take you an hour. Now it's taking you 3 hours. Of course, you're going to be tired. You're going to be cranky. You're going to be sore getting out of the car, and you need to do something to rest. Well, their brain needs more time to rest. And so for people, they are going to sleep to maybe need a mid-morning nap or a mid-afternoon nap, or they need 9 hours of sleep versus 7 hours of sleep. But you don't want them sleeping all day. If they're going to be sleeping all day, they're going to get their nights and their days mixed up. And you need, as a caregiver, you need your sleep too. Even in our communities, we staff more on the day and the evening. We staff minimal on overnights because people should be sleeping. So it's okay for them to have a mid-morning nap and a mid-afternoon nap, but after a certain amount of time, you need to get them up and you need to get them going, or they're going to get their days and nights mixed up. So they do need extra sleep and rest, but they don't need to get their days and nights mixed up. When it comes to hallucinations and delusions, those are absolutely, they can be due to dementia, but it can be due to an outside force. I've had people say, Betty thinks somebody's breaking in her, Betty thinks somebody's breaking in her apartment. We've got to change her meds. I go, well, what's going on? She lives on the 3rd floor. She doesn't have a balcony. She's hallucinating. We went and checked it out. And what happened was the tree outside Betty's window was, tapping on Betty's window. And all we needed to do was cut back the tree. It wasn't Betty's hallucinating and Betty needed her meds changed. We just needed to dig in and find out what was going on. So just because somebody with dementia is saying something, it doesn't mean their meds always need to be changed. It just means we need to figure out what they're hearing or what they're contributing it to, so that we can fix it for them in their world. They were right. Nobody's breaking in the door or nobody's breaking in her apartment, but what is the problem? Because it doesn't always mean the meds need to be changed. Next. So how do we manage emotional expressions? With a lot of patience. And I know that's easier said than done, especially when you're a family caregiver. A lot of times you need to just maybe get up and walk away and take a break, and that's okay. It's absolutely okay. So many times I have families who will say, I don't know how you guys do what you do, because we do it in 3 shifts. We do it from 6 to 2. A new team comes in from 2 to 10. A new team comes in from 10 to 6. You as a family caregiver, you're doing it 24/7. So kudos to you. I applaud any family caregiver who is trying to take care of somebody with dementia, because this is not an easy road. So it's okay to say, I need to step away and take a break. That's why home care has been, created. That's why respite time has been created, because you do have to take a break and take care of yourself. And we have, in a couple more webinars we're actually doing a whole thing on caring for the caregiver. So please join us for that. But, it takes a lot of patience. Even with our own staff, we tell them, if you are trying to take care of somebody and you're getting frustrated and you feel that in yourself, step away and get somebody else to come in and take care of that person in that situation, because we all reach our breaking points. So it takes a lot of patience to do this. It takes a lot of creativity. I always say, does plan A always work? No. Plan A doesn't always work. That's why there's 26 letters in the alphabet. And if you get to Z, then go back to plan AA and then BB and then CC, because it takes a lot of creativity. There's times when I've worked and this has always worked with this resident and today it's not working. Okay, well then let's figure something else out. We, in my building, when people come to me and I say, okay, what have you tried? What have you tried? It's not because I don't believe them. It's because I don't want to go in and try and help out and try to do something's already been done. So it just takes a lot of creativity when working with people with dementia. I will tell you, it takes a lot of humor. When people say, why do I do what I do? I said, because there's never a dull moment in my world. In fact, where my office sits in my building, residents are constantly going by it. And I had a daughter who came to meet with me the other day. And as we were sitting there, a resident had gone in my office and grabbed some papers off my desk and was walking away with them. And I said, oh, well, you'd think by now I would close and lock my door. I would know better. And so things disappear, my office gets rearranged, my lunch gets eaten. You know, so you have to have a lot of humor, because if you don't laugh, you're going to cry, right? As a caregiver. You have to be a detective. Like I just said, when people with dementia are saying this is happening in their world, I've had families say, is it really happening or is it their dementia? I don't know, but we'll figure it out. You know, maybe this is happening. Like someone's breaking in my apartment. Well, we know someone's not really breaking in the apartment, but obviously something is going on. So is it something with the dementia or is it something else? We don't know, but let's dig in and find out what's going on. Because not always do medications need to be changed. Sometimes staff needs to be retrained. Sometimes families need to be educated. Sometimes we just need to do something in their environment to help the person with dementia have peace of mind. We redirect, you know, we redirect out of a situation because something is escalating in their world. So learning how to redirect somebody with dementia, and it's easier said than done. But like I said, the person who wants out, I want out. Well, instead of saying no, 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 I'm used to just saying, well, let's go outside and look. Well, I don't see your car. Do you see your car? No. Or I want to go home. I want to go home. I want to go home. Well, I don't know what your home looks like. Was it a ranch or was it a 2-story? Was it painted white or is it painted yellow? You know, and so being able to redirect the conversation and ask them questions, I can usually redirect a conversation to food in about 10 or 12 questions, and then we go get food. It's probably why I gained a few pounds working in memory care, because I'm always eating snacks and eating food. Providing space. If they do get to a point where they've escalated and they're up here, just kind of back off, you know, provide some space. I tell my staff, you know, you don't have to protect the picture on the wall or the lamp if it gets broken. It's okay. We've got insurance for that. I don't want you getting hurt and I don't want the person with dementia getting hurt. So if they're that agitated and they're starting to throw something, get other people with dementia out of the way, get you out of the way, you know, and then let's give them some space and let them calm down. And once they've calmed down, then we'll reapproach and then we'll redirect. But there's no use in getting in when they're agitated and throwing things and all of that, because somebody's going to get hurt. And the goal is not for anyone to get hurt here. And then being person-centered. If we're person-centered and we're giving them our full attention, because if we're talking and they don't see us, sometimes they're able to read lips, not always, but if we're talking and we're looking a different direction and they can't hear us, our sound is going this way. They can't hear it if the sound is going this way. Their brain is already damaged. So they need to have our full attention and make sure the sound is coming directly at them and not in a different direction. Next. Okay. So what we've talked a little bit about in managing emotional expressions, being proactive is going to be more beneficial than being reactive. So learning to read the signs, you know, it's an entire concept, learning to read the signs. I will tell you, it's much like being somebody who plays poker. Everybody who plays poker has a tell. They know, and you know, professional players and good players can wipe out amateur poker players because they know when they have a good hand and they know when they have a bad hand. For those of you, every single one of us, human beings, as we start to get agitated, as we start to get frustrated, as we start to get angry, everybody has a sign. We really do. I always tell when I'm training or I'm at conferences, if I come home at the end of the day and my hair still looks as good as it did when I left the house that morning, my husband knows that I've had a great day at work. If I come home and my hair is kind of flat, he knows that I've been running my fingers through my hair all day going, what just happened? What did we do? What are we dealing with? I said this to a family I was touring yesterday, and the son goes, you've had a good day today, haven't you? Because it was like 2 o'clock in the afternoon. I go, actually, it has been a pretty good day today. And we kind of laughed. But that's kind of one of my signs when I'm frustrated, is I kind of do this with running my fingers through my hair. I had a gentleman I was taking care of in one of my memory care communities. And when he would start to get frustrated, he would grab his right hand, would grab his belt loop. And we knew 2 scoops of vanilla ice cream with some chocolate syrup, and he would calm down. We had another little lady, when she got frustrated, she would go like this with her arms, and we knew 2 chocolate chip cookies and some black coffee. And if we could sit her somewhere in the sun, even better. You know, so we knew when they started to escalate. Everybody has a sign when they start to get agitated. They'll start frowning, they'll start biting their lip, they'll start pursing their lips, they start breathing heavier. And if you know their comfort food, anything that lands in something salty, fatty, or sugary, you can actually be proactive and not reactive. And you can start calming them down before they ever get to the point where they've escalated. Having a consistent routine is really very, very important. Knowing the person, not the patient, being person-centered and not task-oriented. I teach my staff that when people wake up, people with dementia wake up in the morning, how you start their day off is incredibly, incredibly important. It's kind of like if you get cut off on the road when you're driving. Let's say you have a small child in the car, or you have somebody who, you know, you have a loved one in the car. You may be angry about it later. You're talking about it later. You're still frustrated about it because, you know, that person was an idiot or wasn't paying attention. But being startled over the situation, coming back down to your baseline, it may take you 15, 20 minutes, maybe 30, depending on how close the call was, or depending on if it may have, you know, that could have killed my granddaughter or my child, right? For somebody with dementia, if they are woken up the wrong way in the morning and they're startled and we don't do it the right way, depending on the type of dementia they have and where they're at in their journey, it can take anywhere from 8 to 16 hours for them to come back down to baseline. That's how important it is for us to do it the right way from the get-go in the morning. And those of you at home. So that's how important it is for us to manage emotional expressions the appropriate way. That's how important it is for us to be proactive and not reactive. That's how important it is for us from a communication, from an environment, from an approach, because if we do it the wrong way, that person can be agitated for that length of time. It is so important when we are working with people in memory care and for when we are caring for those with dementia, to be able to care for them, to be able to continue to ensure their quality of life, to enter into their world, because they're never going to continue to live in ours. So I always tell people, I give you a lot of credit, whether you are a family caregiver caring for someone with dementia, or even if you as a professional have chosen to work in this in memory care. This is not an easy task at all. People with dementia are unpredictable. People with dementia are challenging, but I also say that people working with dementia is also very rewarding. I wouldn't have done this for 30 years if I didn't love what I did. So interesting, loving care does not require twice the time. It does require, however, twice the presence. And I really, truly do love what I do. And if at any time you all have any questions or need to reach out, I think the next slide has my contact information. And I'm happy, always happy to help and support wherever I can.
Okay, we're at time now. We're a little over time, and I want to respect your time, everybody. But if you do have a question you'd like to pose right now, feel free to drop it in the chat or unmute your microphone and ask Kathi. Or, you know, as she said, you can reach out to her personally and seek some information. Emily Adams says thank you. Kelly Ibarra, thank you very much, Kathi. Very helpful. It's great. Any questions out there? Just go ahead and unmute and ask your questions.
Kathi, can you talk just a little bit more about what I really liked during the presentation? One of the things that I really liked was talking about not being task oriented. So when you're caring for someone at home, how do you balance, like, do you have some tips on how to kind of balance the task orientation versus really the care?
So for people at home, you know, it's being person-centered is just making sure you're calling them by their name. You know, you still can have a schedule at home and just saying, instead of saying, do you want to take a shower? You know, today's a shower day, so I'll give you 10 more minutes and then we're going to go ahead and, you know, still saying, you know, Jim, We're going to give you 10 more minutes, and then we're going to go take a shower right now. So it's still calling the person by their name, or being caring, loving, being focused on them, not focused on the TV, not focused on the phone, but looking them straight in the eye or touching them. You know, human touch is so important. And again, with COVID, we have to be careful of that in the communities. When we're at home, we have a little bit more flexibility. So that person-centered is actually just holding their hand or giving them reassurance. And I'm going to be right there with you, and we're going to be in this together. Those types of things is being person-centered with them.
That's great. Thanks, Kathi. Kathi, you talk about being the human touch, but what about the touch of your pets?
Oh, that's
and feline. Yeah.
And of course the communities, the health department is not allowing us to have pet therapy back in the building at this point. If somebody wants to bring their own pet for one person, we can do it, but at home, that is so important too. So the four-legged friends at home, you know, having a cat in the lap that they can stroke and pet, having the dogs around. I've even seen from a physical therapy, like someone won't do their range of motion exercise, but put a brush in a person's hand and put a dog up on a table, and they'll brush the dog, and it's the exact same motion. Yeah, so
great.
pets can be incredibly therapeutic, and it's still, while it's not a human touch, it's still, they're getting the touch of another living and breathing thing, and so it equates to the same thing.
That's great. Thank you. Okay, we've got a couple of questions about differentiating between the levels of dementia, between 5 and 6, between 4 and 5.
Those get a little
loaded
blurry.
Questions, but
yeah, those get a little blurry because they muddle together, so it's not kind of a clear-cut thing. But it all depends on the person, and it all depends on the type of dementia. I can tell you, and a neurologist could probably help you better than I can, but I would seeing the person face to face, and I've worked with so many different people in my career, like you can look them up too. If you go into stages of dementia, there's Google, you know, it'll give you some more clear-cut definition, but you go from like stages 4 into 5. There's different things that can happen from a language, from incontinence, from eating. It's going into stages 5 into 6. Like once you kind of get into stages 6 into 7 is where you start seeing like hospice get involved. You see people losing weight. Like 6 and 7, you start seeing people more losing weight, declining in their eating, the communication changes. 4 and 5, people are still pretty active. We see people moving into memory care communities in stages 4 into 5, sometimes 5 into 6, because families will keep them home much more longer. Everybody, I could have 2 people who maybe grew up in the same city, who did the same job, who got diagnosed with Alzheimer's on the same day, and they will actually both take 2 different courses in their dementia journey. They say when you meet one person with dementia, you meet one person with dementia. No 2 people will travel that journey the same way. And that all has to do with lifestyle, how they ate, genetics. I mean, it all depends on the individual person.
Gotcha. Great. We got a question about visiting. If you're visiting your loved one, should you wear a name badge?
Oh my goodness, no. Well, it depends. Okay, let me just say it depends. It truly depends. I actually wore a name badge into a hospital to go assess somebody, and it actually said Balfour on it. And they thought I was from the Balfour store that sold graduation announcements and sold the tap and gowns. And I got kicked out of that hospital room in nothing flat because the woman kept standing up and the chair alarm kept going off, and she didn't want me to sell her anything. Even the nurses wanted to kick me out at that point because I was agitating her so badly. So a lot of times name badges, what can happen, what can trigger is you can come across as a salesperson, or you can come across as something formal and business-like. So I don't always recommend name badges. It really depends on that individual and that person. Right now, I have a family, the daughter's getting really irritated, frustrated because the father keeps wanting, the father was like a high-ranking individual in a company, and he continually wants to have agendas and host meetings, and he doesn't want to do that. And so like in that situation, I definitely would say don't wear a name badge, because you're going to continue sitting in meetings and stuff. And so it really depends on the individual and the family. I always go in and I always say, even with high school friends of mine enlist me a lot to come because their family members dealing with something. But every time I go in, I always extend my hand first and say, you know, hi, Jim, it's Kathi. It's, you know, Tina's friend from high school. I always introduce myself every time I go in and talk to them. So, you know, and I encourage my friends to say, you know, if your family member has forgotten who you are, you can just always say, you know, hi, Mom, it's Kathi, or hi, Mom, it's Jim, you know, hi, Dad, it's, you know, just immediately don't put them through the experience of trying to guess who you are. It's frustrating for them. It's frustrating for you. It's heartbreaking for you. And it just starts off your conversation immediately with them being agitated and irritated. And if that does it, like I said, it can take some time for them to come back to baseline.
That's great. Any other questions out there? Any of our life enrichment viewers out there, if you want to unmute and ask any questions on behalf of your groups, feel free. I hope this has been helpful for everybody.
I will say, in the professional setting, you do have to wear a name badge. It is a resident right. If a state health department walks in and you don't have a name badge on, the community can be tagged as a resident right violation. So in the professional world, you are required to have a name badge on.
Okay, here's another name badge question. Do the residents, is a name badge for other residents something that you would recommend?
I know they do that in independent living and others. In memory care one, I don't think they'd keep it on. I mean, we have a lot of challenges in memory care. So in memory care, we don't do that. And in memory care, we get called whatever we get called, you know. So in memory care, I see a lot of residents who read my name. They'll say, they call me Kathi Balfour. I get constantly called Kathi Balfour at work. But I don't know that our residents would keep name tags on in memory care.
Gotcha. Okay, any other questions out there? If not, I think we're going to conclude for today, and hope you guys all learned something. I certainly did, and continue to check back in with us. Check back if you have questions. Check in with Kathi. She's got her contact information here. If you are, I know we're all over the country today, so feel free to check in with your local Balfour community. We have memory care, you know, advice all over the country. Check in with your local Balfour at a Balfour near you. So I've always wanted to say that. So feel free to do that. We're here for you wherever you are in this journey. Just know that you're not alone. You know, Kathi and I, before we jumped on the call today, we were speaking of both of our parents going into this dementia journey. So whether we're dealing with it personally or dealing with it professionally, we're here for you. That's why we do what we do. And thank you very, very much. Keep in touch. Let us know what else we can do for you, and keep checking in, and come back to our next webinar about dementia. Kathi has generously offered to do this pretty regularly so that and tackle different areas of dementia for you. All right. So thank you.
Thank you,
welcome
guys.
to everyone that said thank you. Bye.
Thank you very much.
Yeah, you're
Thank
welcome.
you. Thank you very much. Very well done.
Thanks, Mary. Yep. Thank you. Have a great Saturday, you guys.
You too.
You too.
Okay.